organizers for having me here. So what I'm trying to do is to bridge the gap between the cancer biology part of EGFR exon 20 variations and the therapeutic conundrum that we see in the practical world. I have no conflicts of interest to disclose. So let's see what the molecular dynamics of EGFR is. We know that the gene lies on chromosome 7, region 1, band 1, and subband 2. The size is around 192,000 plus bases. The amino acid is of 1,210 size. There are 4 isoforms. And functionally, it's a receptor tyrosine kinase that catalyzes transfer of a gamma phosphoryl group from the ATP to tyrosine residues on the protein substrates. The receptor has almost ubiquitous expression throughout all cells of the body. Biochemically, it's a single pass type 1 membrane protein. You can see there's just one alpha helix that passes through the membrane, be it the nuclear membrane or the cell membrane or of the organelle. There are 3 parts to the receptor. One is the extracellular domain, the transmembrane domain, and the intracellular domain, which is the more important one and the conserved one evolutionarily. So moving on to the dimerization. When a ligand binds, ligands being molecules like EGF, TGF-alpha, etc., that leads to dimerization of the receptor. It can either be a homodimer or a heterodimer. That leads to a phosphoryl group transfer from ATP to the receptor, which is the process called autophosphorylation. And that leads to an asymmetric kinase domain dimer, which helps in these phosphorylated tyrosine residues within the kinase domain will actually attract other molecules or substances like SHC, GRB2, and they in turn lead to downstream activation of the usual pathways, the RAS, PIK3CA, all that we know, which is downstream of EGFR. And finally, that leads to cellular growth. Now, we know there is a clinical enigma related to the atypical EGFR mutations. So you can see almost half of the atypical EGFR mutations are contributed by exon 20 variations. Down here, this is the TTF, time to treatment failure graph, where there's a clear demarcation and a poor OS benefit when it comes to atypical EGFR mutations, especially the exon 20. Now, why does this happen? This was a landmark paper which showed that just one insertion, the FQEA, which you all know, was the only one that had a good response rate to the early TKIs. None of the others showed a response. Why was that? That brings us to the genotype quaternary structure relationship. Here, as you can see, and we all know that more clinically relevant mutations happen in the tyrosine kinase domain. And of that, the exon 20 has more of insertions and point mutations. On a closer look, the exon 20 region codes for part of the transmembrane region and the N lobe, which is part of the intracellular domain. And that is part of the tyrosine kinase domain. And this part is important. The ATP binding cleft is actually coded by the exon 20 region. This was a really good paper last year where they sort of divided exon 20 variants into the whole of EGFR mutations into structure-based classification. So they found 4 types: classical-like, T790M-like, exon 20 loop insertions, and P-loop alpha C helix compressive. So these were based on structures of the EGFR depending on what mutation they studied. Now, as you can see, the exon 20 loop insertion When this happens, there are two types called the near loop insertion and the far loop insertions. So they respond differently to the clinical TKIs that we have. Now, why is that? Structurally, what happens is the P loop is pulled down and the C alpha helix is pulled inward. Thus, the hydrophobic core is sort of compressed inside. So these mutations in the near loop and far loop domains, they are sort of resistant to binding of the TKIs. So to start that, like with the T790M mutation, it is thought that it was because of the steric hindrance that they were resistant to the earlier TKIs, because threonine is a smaller molecule, methionine is a larger molecule, so it comes in blocks the ATP binding cleft. But now we know it's not basically the steric hindrance that's happening with these resistance or non-efficacy of first generation or second generation TKIs. It actually, these mutations causes an increase in ATP binding. So with early TKIs, the mechanism is by reversible binding. So they compete for the ATP to bind to the ATP binding pocket. Now, with these mutations, what happens is that the competition is sort of brought down by increasing the affinity for ATP. So that is why you require a covalent binding molecule, which should be an irreversible binder that should replace the ATP and completely prevent binding of ATP so that you can block the entire downstream pathway. Now, the early part, this is the one nearer to the exon 19, the FQA and LQA insertion. These two behave like the classical loop. So that is why they have a different clinical correlation, or the efficacy is different with these mutations, just these two. So what I'm trying to tell here is that, as Dr. Akhil was speaking earlier, it simply doesn't, you shouldn't just look at whether there is an EGFR mutation or whether it's just an exon 20 variation. You really have to go in depth and see what it is actually causing at the structure level. Only then you'll be able to predict the benefit of whatever TKIs you're planning to give the patient. So this is what I've just said, the exon 20. Structurally, it has the code for the C helix and the loop following the C helix. So whatever is nearer to the C helix will behave a little like the exon 19, and whatever downstream will behave differently, and they'll have a different benefit or an efficacy to the TKIs. A graphical representation. So this is what happens in a normal setting. This is the N lobe and the C lobe, which is the molecule or the part or structure that is coded in the intracellular region. This is how it looks like. In the middle, this is the ATP binding cleft. So in an inactive state, when there are no ligands, the C helix, this part, is sort of, it juts out and blocks. So the whole molecule or the whole receptor is inactive. And when there is ligand binding, the C helix is thus pulled inside. The ATP binding cleft is open, ATP can bind, phosphorylation and downstream activations can happen. What happens in an exon 20 insertion? There is an insertion here, addition of nucleotides and thereby amino acids. So the C helix gets pushed into the N lobe. Now the ATP binding cleft is open. So even without a ligand, a natural ligand, the whole receptor and the domain, tyrosine kinase domain, would be active. And this leads to constitutive activation. Moving on to the therapeutics. We know that the mobocertinib, oral mobocertinib is there approved, and the injectable amivantamab is approved based on the Rasalam study. So these are the molecules. Right now we have poziotinib, mobocertinib, the bispecific amivantamab, the HSP90 inhibitor luminescent. So HSP, the heat shock protein molecule, is actually quite necessary for the structural, to maintain the structural integrity. So if you block that, downstream signaling wouldn't happen. These are some of the emerging therapeutic molecules. The ones below all on more than second line, and the ones below they have they do show an ORR, but we are yet to see the benefit in PFS and OS. The others that we spoke of now have definite benefit. Some of the ongoing phase 3 trials, immunotherapy, VEGF inhibitor, and chemotherapy, TAC-788 versus platinum-based chemotherapy, toripalimab with chemotherapy, and amivantamab with chemotherapy versus chemotherapy alone. So these are some of the trials that we are looking forward to with respect to EGFR exon 20 variants. Having said all that, this is the reality that we have. We speak about all fancy molecular testings, reportings, and correlations, but there's still part of the world which have no access to testing at all. So I mean, my message would be that we really need to expand testing. We have to go in depth. We have to sequence all patients, be it upfront or down the line. And remember that there are still patients who do not have access to any sort of testing. So we need to have a global effort to increase awareness, bring down the costs, do extensive testing, and also request companies to bring down costs. Thanks. I acknowledge most of the institutes I've been working with or affiliated with, and wouldn't be here without them. Thank you so much.
Thank you, Dr. Anu. The talk is open for the discussion. Any questions? So I would like to ask one question. How do you see exon 20 insertion now? Earlier, it was only acquired T790M mutation was important to look upon. But how do you see as an acquired resistant mutation of exon 20 insertions? Have you any experience in it, or you see only at the upfront or at the baseline exon 20 insertion?
No, mostly at the baseline.
At the baseline. Okay.
Very interesting talk, Dr. Anu. Regarding this HSP90 blockade approach, which can be universal to all the EGFR resistance mechanism, I guess?
Yeah, it should be. Theoretically, it should be. Yes, because it is well downstream and it's a very critical part of the downstream activation. So that is why we're looking forward to Luminescent trials.
Okay, great. And regarding the initial responses, duration of responses and early recurrence, what do you predict insertion of these variants actually of the exon 20 insertions? Do they have a difference in terms of response rate, which you already showed actually?
Yeah.
In terms of duration of response, they may have early responses and then they fail. Do you have some comment on that? Because there's it's not absolute that you do not see response at all.
Yeah, that would actually depend upon co-mutations as well, I'm guessing, because, and also maybe the clonal part of it. If it's a very small one, patient may benefit from other therapies, and the overall response rate would be different because we speak of duration of response and as a holistic term.
If you were to give an option to choose among all the treatment which you have mentioned, osimertinib, mobocertinib, and all, amivantamab, which will be the best you will choose for the Indian patients?
It would depend upon the scenario that we're dealing with. One is oral, one is injectable. That's a different, that is also important. Patient needs to choose. I mean, I would actually speak with the patient first, put everything on the table, the projected PFS or whatever we're trying to get into, and also the mode of administration. And then we'll actually really sit with the patient and explain all this, and then come to a conclusion, decide which one. And also the amivantamab is a bispecific inhibitor, so we'll also look into the CMET part of it. So it'll really depend on whatever case scenario that we're dealing with. That is.
The monoclonal antibody bispecific EGFR and CMET. When we talk about this exon 20 insertions, which is not happening, which is happening way down in the signaling pathway, and we're just trying to block the receptor over there.
Yeah.
Of the two, like, do you think there's a role for only an anti-EGFR inhibition alone without the c-Met part? Like we have another drug called cetuximab, and amivantamab is half cetuximab and half as c-Met. So from the molecular perspective, from the mutation, from the conformational change, blockade of what do you think is actually providing us the benefit? Is it the EGFR part or the MET part?
Both, in fact, and
does
more of
MET,
the
does
EGFR
MET talk
part.
to exon 20? Is that important?
Yeah,
or
more of the EGFR, I would say.
more of the EGFR.
More of the
So
EGFR.
do you think there may be a chance that even cetuximab may do the same job?
Yeah, we'll have to see. I mean,
Just a
we'll
thought.
have to, yeah. Yeah, that is a great question.
Well, I mean, just a comment that cetuximab would be different than for these heterodimers between the EGFR and c-Met. So, Dr. Anu, now that there are more and more emerging evidences of these exon 20 mutations in HER2 as well, right? And recently the paper kind of like describes them. So whatever you said about the EGFR exon 20, is it totally analogous to the HER2 EGFR HER2 exon 20 as well, and everything would be applicable? Or do you see any obvious or significant
No, it
differences?
would be different. Wouldn't be exactly the same. Though they're all part of the same family, there are differences. And HER2 being unique, as there is no ligand known, it's kind of an orphan receptor. The downstream conformation changes are going to be a little different. I'm talking in a nanoscale level. So overall, I'll have to check.
I mean, a recent report of phase 2 talks about the poziotinib, even for the HER2 to be like, maybe
yeah,
not.
Yes,
So
that's why it depends on what conformation change that is leading to exposure of the ATP binding pocket or not. So if the pocket is open, then your reversible or the irreversible inhibitors may work to an extent. But there are finer conformational differences. That comes down to what amino acid insertions or deletions you're talking about, or what point mutations. If it's almost a similar amino acid, so something like both are polar or both are non-polar, there's not much of a difference that's going to happen there. But if one is polar and it's being replaced by a very bulky with numerous side chains, and that being non-polar, is going to cause some differences in the hydrophobicity. These all lead to steric hindrance and structural conformation differences. At that scale, at that nanoscale, there might be differences in drug binding. So that will also affect the final downstream efficacy that we're talking about. So to be very, very specific, even while designing clinical trials, RCTs, to be really specific, as you spoke about the STK11 and KEP, there are conflicting evidences. You really cannot say that all STK11s are going to be resistant to immunotherapy, or, there might be inter-individual differences, because every patient is different, every tumor is different, everybody has heterogeneity. So that's where precision oncology comes into play. Really have to tailor it down to that patient, that profile, and look at co-occurring mutations. There are mutual exclusivities that happen. So I would like to look at everything at that nanoscale level, so that it will really benefit the patient rather than going about a vague game.
Thank you, Dr. Anu. I'll call upon